Right, we are right at noon for Central Time, and if you are joining us from West River, 11 a.m. Thank you everyone for showing up for the Food is Medicine webinar. This is brought to you by both SDSU Extension and the South Dakota Healthy Nutrition Collaborative. We're super excited. We've had an amazing amount of interest in this webinar. I'm just absolutely gobsmacked by the registration that we've had. So I'm super excited to share some of this information about food as medicine programming, as well as talk about some of the work that we're planning to start in building a food as medicine network in South Dakota. Before we begin, we have a few housekeeping items. The first thing to know is that this webinar is being recorded. So if you do have to leave early or you miss a certain piece of it, do not fret. It'll be recorded and we're going to post it on YouTube shortly after today's webinar. So you'll have plenty of time to access the recording. The other thing is we are going to be presenting a pretty high level overview of these programs, and that is mostly to get everyone on the same page of food as medicine and understanding our network idea. But we also want to take time to hear questions from all of you. And we are super excited to kind of engage in a pretty active Q&A process today. If you have any questions throughout the webinar, you should be able to use the Q&A function in your Zoom controls, and that will get you to uh, providing a question that'll go directly to us, the panelists, and then we will moderate and answer during our extended Q&A session. There is a chat feature if there's anything technical that you need to talk to me or the panelists about. But otherwise, we would prefer to have those questions go through the Q&A feature if possible. All right. So without any further ado, we'll get started. And so again, we're super excited to have everyone here. As a quick introduction, my name is Gemma Bastain. I'm an assistant professor in the SDSU Extension and Nutrition Health Specialist. I also sit on the steering committee for the South Dakota Healthy Nutrition Collaborative. And the aim of that collaborative is to improve health outcomes for South Dakotans through education, sharing resources, and advancing conversation to align actions that lead to collective impact. So we're just super excited to have you here. And then I also have a co-presenter, and she can introduce herself real quick.
Hello, everyone. My name is Olivia Husmann. I hail from Mitchell, South Dakota, and I am currently pursuing a Master's of Public Health and Nutrition Science at SDSU. I'm very grateful to get the opportunity to speak in front of such an outstanding audience, and especially alongside my advisor and mentor, Dr. Bastion. Thanks all.
All right. So, just again, as a quick overview, like we've mentioned, we're kind of sitting in these dual roles for this webinar today. So, I am faculty in South Dakota State University School of Health and Human Sciences, and Olivia is in a graduate program in the same organization. We also work heavily with SDSU Extension, which is the outreach and educational arm of our university. And like we said, we're both very active members of the South Dakota Healthy Nutrition Collaborative. So this is a multi-sector, multi-organizational work that is working in food policy and programming and research around food and nutrition security throughout South Dakota. So this Food is Medicine is just one of our many initiatives through this collaborative. I highly encourage you to check out more of the Nutrition Collaborative if this is types of features that you are interested in learning more about, because there's a lot of great work already happening through that organization. All right, so Olivia is going to start us off with some overview on food as medicine programming.
Thanks, Dr. Bastion. So the idea of using food to promote our well-being is not a new concept. In fact, it has ties all the way back to ancient Greece with the father of modern medicine, Hippocrates, who quoted, "Let food be thy medicine." And it's also just as important to recognize that indigenous foodways have employed the food as medicine concept long before it reached the mainstream. Linda Black Elk with Natifs, the Kea Foundation, and Sichangu are doing some incredible work in this space presently, just to name a few of our South Dakota representatives. And finally, food as medicine has recently been popularized in the rise of bioactive supplements like those found in ginger and citrus, as you see here. And now that's not exactly the space where food as medicine as a healthcare approach lies, but we can certainly lean into that momentum to gain public support for programs. Next slide, please. And a lot of us may be here because we recognize that chronic disease has reached a staggering prevalence within our country. A 2017 secondary analysis of NHANES, National Center for Health Statistics data, and experimental trials estimated that 45.4% of all cardiometabolic deaths within the country are attributable to suboptimal diet, namely low fiber intake from whole grains, fruit and vegetables, and nuts and seeds. We also know that this data likely tracks to the state level, as the vast majority of South Dakotans do not eat enough fruit and vegetables, and a notable number of citizens live in areas considered food deserts. Next slide, please. Thank you. So then, food as medicine emerges as an approach to clinical care with a focus at improving food security and shifting dietary patterns towards those that we know to be health promoting. The Food as Medicine Coalition's pyramid has been circulating for the past few years, and it provides a fantastic visual representation of all the interventions that fall under the umbrella term. We start at the bottom with food policies and programs that have population level impacts. Some examples include workplace policies that strengthen nutrition standards and requiring restaurants to post nutritional information on menus. A step further up, we have programs that specifically enhance the nutrition security of target populations, like children attending public schools, mothers and infants, and those facing food insecurity. And then at the very top of our pyramid, we have produce prescriptions, medically tailored groceries, and meals, which typically involve providing reduced price or free produce or meals to patients with chronic disease and an identified social need. Dr. Bash will provide much more detail and more examples of these interventions in just a bit, so tune in for more. Next slide, please. So, in a little bit of historical context, the oldest recorded explicit food as medicine program was started by a doctor in the Mississippi Delta region in the 1960s who provided his patients with prescriptions to be redeemed at the grocery store. He was also a notable member of the Medical Committee for Human Rights, which reflected his desire to address food accessibility among his patients through a community healthcare model. And interestingly, WIC actually qualifies as the country's largest food as medicine program and exists as one of the oldest in the country in its provision of tailored grocery items to participants at risk of food insecurity and iron deficiency anemia, and inclusion of a nutrition education component. Next slide, please. And food as medicine is really uniquely positioned for collective action and endorsement, thanks in part to the direct nod it was given during the 2022 White House Conference on Hunger, Nutrition, and Health, where it was emphasized as a strategy to improve food and nutrition insecurity and achieve the national goal of ending hunger and reducing diet-related chronic disease by 2030. This formal recognition catalyzed funding, interagency coordination, and policymaker awareness. And we know it continues as a prominent talking point among the current administration. Take, for example, the Make America Healthy Again movement and the colloquial tagline of the new dietary guidelines, Eat Real Food. And now that we have reviewed some of the background and historical context of food as medicine, I'll hand it off to Dr. Bastain to share some more examples and talk about the work that's being done in our state.
Thanks, Olivia. Great job, like always. All right, so I'm going to dig in a little bit more about some of these food as medicine programs. We gave you a quick overview of the pyramid already, but I'm going to just provide a little bit more context, a few examples, so you can kind of get more of a visual of what these programs look like. And again, we'll then wrap this up with talking a little bit about the network, what our plans are for building this network, and then we'll have plenty of time for Q&A. I'm already seeing the questions coming in, which is really exciting. So we're going to start from the bottom of the pyramid, looking at some of these population levels. We're going to talk a little bit about nutrition incentives, also known as double up programs or double up food bucks. And so we'll take a look at those. In the middle of the pyramid is produce prescription programs, also known as Food RX. And so those of you who know me and my work know that I've been very active in this area. And so we'll talk a little bit about those as well. And then finally, we'll wrap up with some medically tailored meals and groceries. This really is an initiative that I personally have not seen yet in South Dakota, but would be a really wonderful avenue to expand some food as medicine work in our state. So, looking at nutrition incentives or double up food bucks, these are programs in which people who are utilizing SNAP, Supplemental Nutrition Assistance Program, or EBT benefits, can double the amount of fruits and vegetables that they are able to acquire with those dollars. So, for example, if someone is spending $5 on their EBT card to buy fruits and vegetables, they can actually, through these programs, get $10 worth of produce. And so, this is obviously a fantastic program for increasing the purchasing power of people with limited food resources, as well as encouraging people to eat more fruits and vegetables, which we know is one of the main shortfalls in the average American diet. A lot of these programs are funded through a USDA mechanism called the Gus Schumacher Nutrition Incentive Program, also known as GusNIP. And South Dakota State University Extension is very fortunate to be part of the newest cohort of grantees for this program. So that was officially announced in a press release a few weeks ago. So we're super excited to now share that we have this grant. And we are planning on implementing this throughout, particularly some of our most rural counties in the state that have the highest prevalence of food insecurity. So our plan is to collaborate with the local grocer, Bowie Foods, that operates again in kind of that central southern South Dakota area, as well as working with some of our farmers markets that accept EBT benefits during the market season in order to have this double up food bucks program for people on SNAP. The nice thing about this is that it also really helps us provide that complementary nutrition education as well. Because if we're going to double the amount of fruits and vegetables that people are buying and using in their homes, we're also going to have to provide that complementary education on how to utilize them, what types of recipes, how to get your kids to eat fruits and vegetables that they might not be as familiar with, and all of those sorts of things. So again, taking a look at our current grant, we are really in the beginning stages of this. So even though we can officially announce that we have the grant, we're still working with USDA on the final touches for it and kind of figuring out our evaluation plan. So this is from our initial proposal, but please note that this is absolutely subject to change at this point. You can see that the yellow stars throughout the state are where those Bowie Foods grocery locations are, where those double up bucks will be happening. One thing to note is that I do believe that the one in Sisseton will be closing, but we do plan on expanding to a new Bowie location in Mobridge. So we'll still be in those rural high food insecurity areas. You can also see that some of the solid pins on this map show farmers markets and direct market firms that offer EBT benefits. And we have been in past communication and we're working on rebuilding those networks to offer it at those types of farm direct sites. And then some of the kind of more transparent pins are where there could be potential expansion firms. And one of those places are the blue pins where we see Bowie Gus stops. And these are convenience stores that also sell some grocery items and could be a spot to kind of fill in some of those gaps in really rural areas where it is a little bit further to get to a grocery store. So again, this is extremely new, hot off the presses. We're still working through some of the details, but we're very excited to finally have one of these programs in the state. And just because we have this one grant doesn't mean that we couldn't continue this process in other high needs areas. As someone who moved here from New Jersey, I know very much about urban food insecurity as well. And I know that that exists in our urban areas throughout our state as well. So there's definitely still plenty of opportunities to continue offering increased purchasing power for our SNAP population. Uh-oh, I keep on double clicking through these slides. All right, our next program is Produce Prescriptions or Food RX. And so this one I think a lot of people are familiar with. But just for those who might be unfamiliar with this process, this is really a collaboration between healthcare providers and community food partners. And basically, it is to allow patients who have either chronic disease or are at risk of developing chronic diet-related disease to have access to healthier foods, particularly fruits and vegetables. But I've also seen RX programs that have fresh herbs, that do eggs, even meat. It really can it can be pretty wide reaching. But the idea is to have that access to healthy foods, but it's more medically managed in the way that people who utilize these benefits, it's not just because they're on SNAP, it's because they have one or more chronic health conditions, and they're also experiencing either low socioeconomic status or food insecurity. So this is a little bit more on that disease management side, but not completely medical care in the way that medically tailored meals and groceries are. So, looking at what these programs can look like, there is an extreme amount of diversity in Food RX programs and how they're managed. Even here in South Dakota, there's about four projects that I'm aware of, and they all run a little bit differently through different avenues. On the healthcare provider side, you can see physicians, nurse practitioners, registered dietitians. These are all healthcare providers who have like the authority or the clinical judgment to look at a case, realize that they meet the criteria for a program like this, and could potentially refer or enroll people into a produce prescription or food RX program. You can also see that it can also be very broadened. We've, through our pilot project, which we'll talk about in a moment, we've worked with community health workers before. Other programs will work with social workers, with pharmacists, with WIC clinics. So this is really an opportunity to expand healthcare access, especially when we think about rural areas where there might not always be a physician or around or enough physician access. Looking at the food retailer side, very similar to the double up bucks. This can be in a variety of different food retail environments. The most common ones would be grocery stores and supermarkets. For those who live in Sioux Falls, you might have heard of the Food as Medicine study by Avera Research Institute. This is a prescription program where people are able to, well, they were randomized. So some of them were able to pick up produce at Hy-Vee, and other ones actually got boxes delivered to them. But that would be one through a grocery retail chain. It could also be through corner stores for places with less access to those larger markets. It could also be through emergency food, like food pantries or food banks, even delivery services. Some states have partnered with Instacart in order to deliver produce prescriptions. And one place where I've really focused is working with local food vendors. And so many produce prescriptions also operate through farmers markets and farm direct firms. And particularly, I've been working on a really cool project with community supported agriculture, or CSA. So, just to talk about that for a little moment to give you an example of what these programs look like in practice. This is our pilot program called Dakota Food RX. We just wrapped up a 2-year pilot of this program that was funded through the South Dakota Community Foundation Beyond Idea Grant. And so we had 2 growing seasons to kind of work through this program. And this was a produce prescription program that connected patients with local farmers throughout the state. So the cool thing about this program is that instead of providing vouchers to the patients to go to a grocery store or another food site and get a certain amount of dollars worth of produce, instead these patients were enrolled in a full CSA share. So throughout the growing season, they were eligible to receive a CSA share just like anyone who paid for a full share of that community supported agriculture. And they were able to get that for free throughout the whole growing season based on our conditions of the grant project. So you can see, the sampling of produce at the bottom picture on this slide. There's a lot of variety, and the nice thing is that all of the farmers that we worked with, they either are certified organic or they grow using regenerative practices. And so not only is the food, fresh, it's often, it's very local, so it keeps that freshness. Often fewer pesticides, preservatives, all of that. And it also puts money back into the local economy because, through the grant, we're able to subsidize those CSA shares. So it also helps those local farmers. So and I can't even take all the credit for this program because I'm like, wow, this sounds like a cool idea. It really comes from building on past successes in other states, and particularly the farmer up on the top corner of the slide, Jared Lukens Black of Budding Moon Farm. He really had been running a similar type of program just at cost through his own farm share. And he was the one who really was gung-ho about, spreading this to other farms. And so working together, we were able to expand this to three other farm partners, work with several healthcare partners throughout our state, mostly in the Black Hills, but we were able to move a little bit into eastern South Dakota as well. Um, Through the pilot years, we overall enrolled 46 different families through the program. And so, again, they received those boxes from June to about October, November. So it isn't a full year access. But one of the really amazing things that I found through this. So we did a bunch of evaluation, including interviewing patients who are part of the program. And one of the questions that I asked the patients was, what are, what, how do you feel about the program ending? How do you feel about basically, having to go through the winter without this extra access to produce? Thinking that people would, state that, yeah, how am I going to be able to do this? It's going to be really challenging. And what I saw instead was like a lot of resilience from these folks. And maybe I just underestimated the resourcefulness of this population, but they were just so grateful to have this access during the growing season and to know A, what fresh vegetables taste like, but then they worked either through preserving the vegetables, so maybe they froze excess or they dehydrated herbs. Um, or even folks who went through all of their fresh produce, they said, now I know that that vegetable exists and I can go to the grocery store and I can get it in the winter. It might not be as fresh, it might not be as tasty, but now I know about it and I know that I can feed my family that and I know that they'll like it. So just a really fantastic program. We just recently had a manuscript on the outcomes of this program accepted for publication in the Journal of Agriculture, Food Systems, and Community Development. So that'll be really exciting to share once that's officially published. But that just is one of many examples of what a produce prescription program can look like. And moving into our final category, kind of towards the top of the pyramid, is medically tailored groceries and meals. And like I said, we really don't have, to my knowledge, any programs like this in South Dakota, or at least formally marketed as such. But this would be a wonderful opportunity to kind of build our food as medicine network and our options for patients throughout the state. So, what does a medically tailored meal or grocery look like? These are programs that are going beyond a produce prescription or a food or X, where people can pick up certain foods, and they're specifically curating either groceries that are delivered to a patient or full meals that are pretty much ready to heat and serve to patients. And usually these patients are at the more acute end of the spectrum. So they're dealing with complex chronic diseases. They often have limited ADLs. So these are your patients that are mostly homebound, have transportation issues, are really having those issues with accessing and might not be able to take, for example, CSA share and turn that into a meal due to kind of reduced ability. And so, like it says here, typically home delivered, or it could be picked up at a partner agency. So you go to a food bank. A lot of them partner with services like Meals on Wheels to deliver programs like this. And again, just like produce prescription, just like food incentives, these are associated with improved healthcare outcomes. Reviews have shown that there's lower risk of hospitalization and monthly healthcare expenditure. And again, because these patients are quite complex with multiple chronic diseases, that's a huge cost savings as well for healthcare systems. So it's definitely a good investment in preventative health for sure. Um, like I said, there's not a whole lot of examples out here. One example, again, I'm from the Northeast, and so I've worked in partnership with a lot of these programs for most of my career at this point. And one example from New York City, which I think is it really highlights programs like this. It's called God's Love We Deliver. And this is an organization that's been around for, gosh, for years, at least over 20 years, probably closer to 30 at this point, if not more. And this program originally started to work with people who are living with HIV and AIDS. Who again, that is a disease that leads to a lot of complex chronic conditions, makes it really difficult for patients to be able to go outside, have those access to certain programs. And you can imagine in New York City, a city like that, it makes it even harder to kind of navigate. And so the program started there, but I think over the recent years, they've really delved into anyone who's medically complex. So it really allows for people to get again those tailored groceries or meals. And I guess another thing I can say about this is that the medically tailored groceries and meals, those are almost always in collaboration with a dietitian or other healthcare professional who can, utilize that, look at the chronic diseases that the individual patient has, and develop a meal plan that meets their dietary needs. So these are highly individualized programs because they're working specifically with what the patient individual needs are. And then with the meals, those are often also in collaboration with the chef or some type of culinary operation because, of course, food cannot be medicine if people don't eat it. And so, it's very important that those meals are palatable and that they, work for a large portion of the population and have cultural considerations involved. So, definitely a program that involves a lot of work and planning, but can have a lot of huge impact on that very acutely complex population. So, done a lot of yapping about what food is medicine is and what the programs look like. So now I want to transition a little bit into what a Food is Medicine network could look like in South Dakota, which is really kind of the main thing I want to discuss today. Um, so just looking here, there are food as medicine networks in several other states. It's definitely less than half, but it is a growing movement to have people working together on these collaboratives to figure out food as medicine programming in a state. And as you can imagine, just from the examples that I've shared with you today, there is a lot of coordination. There's a lot of community partnerships that need to work in order to operate a program like this. So, for example, Dakota Food RX, we had the staff here at SDSU Extension who were managing the program and running evaluation. We had students helping with educational resources. We had farmers all across the state that had slightly different CSA models that we had to work with. They had to work with our financial office at the university because you can imagine kind of getting those invoices done through a university setting can have a little bit of red tape there. We also had a variety of healthcare providers at different medical institutions with different ways of seeing and reviewing charts and enrolling patients into the program. And so that is just one example of a program that takes a lot of different partners and people to successfully operate. And so you take that and you multiply it by multiple different types of programs looking at different outcomes. It takes a lot of people to do this work. And so rather than working in silo, having a food as medicine network will allow those partners to come together to resource share to build. And you can kind of see from these examples listed on the screen, food as medicine networks are not exclusive to just urban areas or rural areas. They're not exclusive to blue states or red states either. This is really a type of network that can work in just about any state. It can be highly individualized to the needs of the state, and it can really help move programming forward. I think a really great example, and some colleagues that I know are part of the Florida Health and Nutrition Coalition, which is the food as medicine network down in Florida. As we all know, Florida is also a quite conservative state. And again, not to generalize here, but a lot of times it is a little bit harder to sell the idea of preventative health programs and public health programs to a more conservative state legislature. But because they had the power of working together towards this goal, they were able to actually pass legislation to have Florida apply for what's called the Medicaid 1115 waiver. And basically, that is a waiver. They're not available at the moment, but they're waivers that you can apply to the Medicaid program to allow for innovative pilot projects. And so, because of that, they were able to offer prescription programs and other food as medicine programming to people who had Medicaid health insurance, and it was paid through the program. And so they didn't have to worry about finding additional grant funding or foundation funding or philanthropic funding in order to fund these programs. So just a really amazing way that people can come together and really find outcomes that are very state specific and work for their each unique population. So, if I haven't already convinced you that a food as medicine network is a really amazing idea, just some more reasons as to why networking and coalition is really impactful in this space. The first thing is reducing reinventing the wheel. I tell my students all the time, there's nothing wrong with the wheel. The wheel is excellent. There's a reason it's been around so long. And that's just basically, when you're working in silos and you have different organizations running different food as medicine projects, sometimes you're all working on answering the same questions at the same time. And so rather than utilizing everybody's time and energy to solving the same problem multiple times, you can come together and work on a collective solution. So, for example, one of the issues that we ran into during the Dakota Food RX pilot is having patients participate in our evaluation process. Um, you can imagine we have a primarily rural audience for that program. They were mostly skewed older. And so they're getting this program where they're getting all these fruits and vegetables and they're mostly interacting with a farmer. But then you have this crazy lady from the university saying, "Hey, can you fill out all these evaluation forms? Can we schedule a research interview with you?" And there was a lot of hesitancy to do that. And so obviously that is a problem that we're trying to, straighten out as we apply for more funding and trying to see what's next for that project. But there are other organizations that are dealing with the same thing. Research hesitancy isn't a new phenomenon. And so rather than all of us trying to solve similar problems in silo, we can work together and find solutions that kind of work for the unique state that South Dakota is. This also limits stepping on toes. I think the other thing is that because a lot of these programs are grant funded through competitive opportunities, through USDA and other mechanisms, it's very easy for people to feel competitive in this space and say, okay, well, this is my proprietary idea. I don't want anyone to steal it. I'm in competition with these folks when the RFA cycle comes along. And the truth of the matter is, South Dakota is a small state. We need any grant funding that we can get funneled into the state as possible. And so rather than trying to keep all these plans for building food as medicine programming proprietary or confidential, we can work strategically. And that doesn't mean that we need to share the entire application, the entire proposal that we're writing up on grant work. But what that means is we can strategically think about if we're working with this priority population and this group is working with this priority population and this geographical location, we can cover more parts of the state rather than, multiple institutions all trying to start up something in, let's say, Rapid City, for example. And so that way we can be more strategic. And then also, because of that, we aren't necessarily in competition. Everyone's success is a shared success because if somebody gets funded, that doesn't necessarily limit the chance of someone else getting funded for a different project with a different priority population. It also shows that we're thinking of our different patient populations throughout the state and finding innovative and individualized solutions for each of them. I think a network is also super important because it ensures that we all speak the same language. I'm sure everybody on this call today learned at least one new term from whether it was food RX or medically tailored groceries and meals. There's a lot of terminology. And I know that there was just looking at the sign up list, there's a lot of folks on this call that are just interested in getting healthier foods in their communities, in their schools, in their kids' lunch boxes. And so there's probably folks who are just like really passionate about this and don't know any of this world. And so we need those types of people in our networking as well, because that's where we get the passion, that's where we get the real urgency for this work. And to make sure that we're all speaking the same language just allows us to better communicate these things when we are, for example, writing grants, talking to media, talking to legislators about our ideas. It just allows us all to speak the same language. We also learn from each other's best practices. Again, if somebody's doing something really well, we want to be able to replicate that. If someone has learned that something just doesn't straight up work for a certain population in South Dakota, then we can learn that as well. And then finally, it just helps us build this infrastructure. So, like I said, we have one double up program, maybe four produce prescriptions. A lot of them are wrapping up, and no real medically tailored meals groceries in this pyramid. So, we have a pretty unbalanced pyramid if you think about it. So, we can work on filling those gaps and building that infrastructure together if we are in coalition with each other. So, a few details on what we are naming the South Dakota Food is Medicine Network. Our idea for this network is not to give everyone death by meetings. We know that we all only have so many hours in the day. Um, I'm a professor and I sit in meetings all day, so I totally understand. But what we want is an opportunity for people to continue to network and continue to build these things and have that opportunity to connect with folks that could then potentially be collaborations outside of regularly scheduled calls. It can be the beginning of new partnerships. And so, what we would like to suggest is starting a meeting frequency of quarterly. And our plan is to begin that in April. And these will mostly be virtual, but if this is successful and people have interest, we could potentially plan an in-person meetup for the Food is Medicine Network too, which could allow us for deeper networking and also like kind of like long-term strategizing. So at this point, we're fluid, and so we can really change the structure depending on the needs of the group. Who do we want in a group like this? We want you. And we want you regardless of if you live in South Dakota, if you work for South Dakotans, or you're just interested in rural healthcare. We want you as part of our group. And so just looking at some of the folks here on the screen, I know that many of these categories fit people who registered for this call today. So we have public health professionals, healthcare providers. Obviously, the healthcare providers, especially on those clinical ends of the spectrum, are so important because those are the people who are going to be able to speak the clinical language to identify patients at risk, work through the HIPAA stuff that can be really challenging for someone in a university setting to do. So there's a lot of benefit of having healthcare providers who can provide their time for that. Looking at people in the food system, producers, gardeners, naturalists. We're looking for people who really understand the connection between land and food. You know, we think about eating real food with this new dietary guidelines. That means food that, we know where it comes from. It's from the ground. It's fresh. It's connected to our cultures. And, thinking about, we also have 9 federally recognized tribes. We're going to also need people who understand those indigenous foodways and understand the importance of, that connection between the land and our food and our bodies. Retailers, grocery associations, obviously very important as well. Chefs, hospitality, again, food is not medicine if we can't eat it, and so, or will not eat it. And so having palatable, healthy food is really important. Educators, we need people who are just willing to teach other people about these concepts or are interested. One of the main gaps in this area is the K-12 population. And so this could also be a way to kind of build a case for building some more food as medicine in more of a K-12 population, which is one of the questions that we've gotten um, already in the chat. And then parents, concerned individuals. Again, we need people with that passion for this types of stuff. All right. So looking at what's next for the South Dakota Food is Medicine Network, we've already scheduled our first meeting, just because for momentum reasons and just to keep up the movement in this work. And so we would like to invite you to our first formal Food is Medicine Network meeting, and it will be on Thursday, April 9th, 2026. It'll be at the same time, so 12 to 1 p.m. Central Time or 11 a.m. for those in West River. We are going to be sending the Zoom link out over the South Dakota Food is Medicine Network email list. So if you remember registering for this webinar, you received kind of a checkbox of whether you wanted to be added to this email list. So if you said yes, congratulations, you're already on the list. If you said no and you want to change that to a yes, we are planning on building a Food is Medicine homepage on the SDSU Extension website, which will have the link to our YouTube recording as well as an opportunity to sign up for that mailing list. So that will be shared with all attendees. So that way, anyone who has that ability. And then if you said yes and for whatever reason you decide, you know what, this isn't for me, you can just contact us personally and we're more than happy to take you off the list. Because not only do we all have plenty of meetings, I'm sure we all have plenty of emails as well. So with that, like I said, I wanted to take plenty of time for Q&A. And so we're gonna kind of transition into that section in just a moment. But before we do that, I just wanted to share the contact information for both me and Olivia. We're more than happy to answer any of your questions about this network. Olivia is going to be taking a lot of leadership as this is the focus of her nutrition graduate project. And so we're both super passionate about this type of work, and we're just excited to connect with all of you. So feel free to write this down, take a screenshot so you can contact us beyond the webinar. And with that, we thank you for being part of this, and we're going to transition into that Q&A session. All right. So I'm just moving things to different screens so I can read everything. Our first question is coming from our chat, actually, and someone is asking, I would be curious if you folks have a framework for food RX in a school district setting. And this is a great question. This is something that I have definitely run into already. And knowing that a lot of these Food RX and even the other food as medicine programs are really geared towards adult populations, right? It's people who have SNAP benefits to spend. They're, people. Adult patients with chronic disease. And so there are trickle effects down to the family when you are working with households with children, but I really haven't seen all that much in the literature on food or X programs that are specifically geared towards pediatric populations. That being said, obviously, this is a population that we don't want to overlook. There is just as high of a rate of chronic disease, obesity, all of these health concerns in this population. And so I think that's something that we can explore. I think the real important thing is we would just need partners that would be able to navigate what that looks like in a school district setting, right? What do HIPAA concerns look like for there if there is a medical referral into a program like that? How does that operate in a school? I know that in South Dakota we have backpack programs, and so kids can pick up a backpack. that has food, shelf-stable food that keeps them, full over those long weekends, in case they're dealing with food insecurity at home. It's a great program, but there's also some stigma attached to that. Eventually, the kids realize what those backpacks are, and there can be stigma with receiving food from a school setting, where you're with your peers. And so there's just like a lot of questions to work out through that. And I think it's a really great way to explore. We just need more of those K-12 partners to really help us work through that space. All right. So moving into our Q&A, which is quickly filling up. So thank you all for your wonderful questions. We're going to start with the first question in the queue. So what ways does the Food is Medicine Network project envision working with Meals on Wheels? Seniors bear the burden of chronic disease and can benefit from the age-appropriate meals that these programs provide. And just to note that Meals on Wheels starts at age 50, and seniors are often left out of such conversations. I think that this is such a great point. And this is something that we've actually been thinking about with Dakota Food or X since the very beginning. When Jared and I first initially wrote our proposal, we reached out to some Meals on Wheels programs in the area to see if there was any feasibility, because we know that transportation is such an issue. Um, at the time, it just wasn't going to be feasible. And so we just wrote it into our project that patients do have to pick up. We do have one patient that just is completely homebound, for medical reasons, and we do budget some money and time to do home deliveries for that one patient. But you're right, there's so much more that can be done, especially when we're thinking about rural South Dakota. If mobility is already an issue, it's going to be even harder. We also have patients who have like other caregivers doing pickup because they do have mobility issues, but they do happen to have like family resources that can go pick up the produce. So this is definitely an area that we want to explore. I love Meals on Wheels. I think it's such an important program, and I think this is also a way to kind of help hopefully fill some of those current gaps in federal funding for such programs. So I absolutely think that Meals on Wheels is the perfect type of venue, particularly for meal delivery. And so that could definitely be an option for expanding into our senior population. All right, our next question is, from my colleague over at Louisiana State. Um, I'm sorry, you're at Oklahoma State now. Everyone keeps on moving in the academic world. But she is curious how extension plays a role in connecting healthcare, food systems, health, and agriculture. That's a really great question, Neela, because that's exactly what I feel like is my goal as an extension specialist. Um, and so I definitely agree that it is extension is uniquely positioned because we have people who can help with agriculture. We have people who are in the health and wellness. I think one of the things that is a little bit harder for extension to get into, or at least in our extension service here in South Dakota, has been working with healthcare partners and really getting into that clinical service. I think we're very good at like the community health. We're managing the double up program, even the produce prescription. We're not collecting any electronic health records. We're not doing any kind of like clinical observations with patients. We did all surveys and interviews for our process aims for that project. And so I think that that is kind of like the next step and one of the limitations of extension. But overall, I think the nice thing about extension is that it's not just the health and wellness people that can be part of this. We have some interest in our unit from horticulture. We have one of our horticulture specialists who will be involved in kind of the planning team for our next Dakota Food or X project. So that's a great way. We have some community vitality, rural development folks who are very interested in agritourism and kind of helping local business. So I think there's a lot of opportunities for extension to get involved. And I know that many of my own extension colleagues are here on the call. And I would say that this is a very an open invitation for folks from any unit and extension to join our network. All right, let's look through these questions. Wonderful. Okay, so this one is from our WIC program here in South Dakota. Thank you, South Dakota WIC, for being a part of this. I know many folks are on the call today. And Carolyn is asking about Park RX, which is already a program that WIC is involved with. And so basically, they're helping with referrals to our Park RX program, which essentially is similar to a Food RX, except they're getting out to parks to exercise and do trail walks and kind of get that physical activity component in. So getting the staff involved in Food RX, again, it's going to depend a little bit on the program and what that qualification is needed for a specific program. But I think WIC is a program that collects enough information to be able to potentially refer patients into a Food RX program. And so, just to give folks an idea of what eligibility looks like for Food Rx, again, it's a little bit different, but there usually is a chronic disease component and an income eligibility component. So WIC already is like great on the income eligibility component because there's also an income eligibility for WIC. So there wouldn't be further means testing in order to say that a patient would be eligible for a Food Rx program. But I think the chronic disease thing is again, through that assessment that's already happening through the WIC program, you would be able to kind of pick up on certain chronic diseases such as prediabetes, diabetes, high blood pressure, cardiovascular disease, history of stroke, those types of things that would put people in that eligibility. I personally have steered away from using overweight obesity as like a diagnosable concern, just as my own personal approach. But there are other programs that do utilize that as a criteria. So I think, finding the right partner, and again, there are partners already in the state, but I think, we really do want to expand and build this out. Um, Finding the right partner who is willing to use the diagnostic codes that are already being used in WIC to help enroll patients into the program will be the best way to utilize that. Because otherwise, I think that is a beautiful way to refer patients, especially because there's already contact with those high nutrition risk patients in that program. All right, going through our chat. Some schools do have food pantries in them. So again, another way for food access. And again, I absolutely agree. It's just, sometimes it's working through that stigma. I think there's just like still a lot to work on in figuring out food as medicine in the K-12 setting. And so there are definitely ways to do it. It just hasn't been really done yet. And so it could be a way that we stay innovative as well in South Dakota. So I'm very excited for further work on that. Um yeah, and then just some comments on the Meals and Wheels program. Some Meals on Wheels have frozen meals without a delivery aspect, so pickup only in the last few months. And again, I think that's just funding changes. And so there are multiple different Meals on Wheels programs throughout the state of South Dakota with different serving service areas. And so I think that's important to know about Meals on Wheels. And so, yeah, there's been some pretty steep funding cuts for that program. And so any way that we can get them back to hot meals or, delivery will be absolutely fantastic. And it'll just involve a lot of just more coordination. All right, cleaning up my Q&A here. And I believe there's one or two in the chat. All right, so yes, so just more collaboration from other states, which I'm more than happy um to work with other states on this as well. I know we're not the only state that is trying to build out uh this type of network. And so any way we can resource share, more than happy to help. And then someone else is saying, what about using farm to school as part of a food as medicine network? And I think that these are the types of food systems connections that I've been working with like our nutrition staff on of like sometimes it's not going to fit like the USDA GusNIP definition of like what a produce prescription program is or what a nutrition incentive program is. But if we are creating food systems and foodways in our communities, in our local communities that are getting more access to healthier foods to people, is that not food as medicine? And so I think that farm to school is an avenue. We are currently in the process of hiring a new staff at SDSU Extension that would be like nutrition and focused a little bit more on that farm to school. But South Dakota has a really robust farm to school network already that has a lot of professionals working on building up this network. I think one of the kind of opportunities for growth that I see in farm to school in our state is just connecting producers with food service. Sometimes geographic location is not ideal, right? Like maybe you're growing in an area where the school districts are just not ready for farm to school or are, a little hesitant or don't have the budget or don't have the staff. And so sometimes finding that match, that perfect like farmer institution partnership can be a little challenging. So I would love to see more built in that area just because farm to school is I don't know. I just think it's really wonderful. I had a master's student do a research project on farm to school and just had a lot of fun with that program. So I'd love to see how we can incorporate that in our schools. I think that is a way to kind of get more access to K-12 youth. And then if we can find a good non-invasive way to show some clinical outcomes from the benefits of offering some more local foods in the classrooms or in school cafeterias, I think that would just be tremendous. All right. So that was a really, really great, robust Q&A session. There are a few minutes left on this call if anyone else has a burning question. And if you want to speak it out loud, I do have the option to allow someone to talk if anyone's brave enough to do that as well. All right, one last question here coming into the chat. How are community health workers involved? Great question. And this is something that in our program, in our pilot, we started this work because sometimes it's just easier to connect with a community health worker than it is with a physician. It really depends on the organization of the institution, right? Sometimes physicians are doing it all. Sometimes there is a much larger network. What we learned as we were trying to delve into the Sioux Falls community, the clinical partner that we were working with, the community health worker was the person to connect with in that because she had the direct contact with those patients who needed those extra services. So for us, that was kind of a start of moving into that space. But I mean, community health workers work in so many different contexts that it could really be a way for them to kind of promote the program in more rural areas. So it could be more of a promotion. It could be a clinical referral if there's access to health records there. I think there's a lot of ways to get them involved. And again, as we are needing more healthcare workers, aging population, workforce development. I think community health workers are a really great way to kind of like continue to have manpower to work on these like larger health aims, without always having all of these, clinical requirements in terms of like education. And then finally, I see someone asking, who are the producers in Western South Dakota? That's a great question. And I don't mind shouting them out because some of them are on this call. But through our pilot, and again, things are going to change as we're trying to work on funding. So it's probably going to be scaled down a little bit this growing season. But right now, we've been working with two growers in Spearfish, Cycle Farm and Budding Moon Farm, and then also with Bear Butte Gardens, which is near Sturgis. So those have been really fantastic partners for our program. And so we're just trying to see how we can continue to move that forward, but also um, increase sustainability because we can't be running into these crises where the funding runs out and then we immediately have to pivot. All right. Well, we are right at 1 hour. So I just want to thank everyone once again for being part of this webinar. I think this is the beginning of something beautiful. Like we said, we will be posting this on YouTube. If you have any questions in the meantime, you have our contact information. It's also available on the SDSU Extension website if you didn't get a chance to write it down. But I'm really looking forward to meeting more of you. And for those of you I already know, I'm really looking forward to connecting more and kind of building a real robust network in South Dakota. So thank you and have a great rest of your day.